today I'll be discussing a case that highlights a rare but clinically significant finding we had during one of our C-sections, which was ectopic decidualization of the posterior uterine wall. This case is important because although decidualization is normal and an essential part of early pregnancy, the occurrence outside the uterus presented really dramatically and unexpectedly. It can lead to significant hemorrhaging and create a diagnostic dilemma during labor. So our aim today is to shed some light on this under-recognized condition, highlight its clinical implications, and encourage further research and maybe awareness of similar cases. So to begin, if we could focus on the right side of the presentation, let's just briefly revisit the concept of decidualization. The endometrium, which is the inner lining of the uterus, prepares for pregnancy in a highly hormone-driven process, mainly under the influences of progesterone. The progesterone causes the endometrial stromal cells to undergo structural changes, such as the tissue becoming more thickened and more vascular, immune cells moving in to protect the developing embryo, and the glands becoming secretory. The environment becomes more optimized for implantation and placental development. If we could refer to the image of menstruation on there, we can see that decidualization essentially occurs cyclically every month within the endometrium, and it depends on if the uterus becomes pregnant or not. Without pregnancy, the decidualized tissue sheds as menstruation. With pregnancy, the decidualized endometrium becomes the maternal side of the placenta, and increased vascularity allows the placental formation. This is the case with physiological decidualization, and it's essential for maintaining an early pregnancy. However, if the transformation occurs outside the uterus, particularly where endometriomas are, things can become more complicated, which is what our case study is based on. So there's a theory of why ectopic decidualization occurs in some women and not in everyone with endometriosis who becomes pregnant. So what we know so far is that the endometriomas frequently have endometrial tissue which is partially progesterone resistant. This is because they express low levels of PRB receptors. They're the ones that respond to the progesterone to cause the decidualization. But because of the low levels, normal endometriosis doesn't go through decidualization even during pregnancy. So the theory is that this particular woman might have had high levels of PRB expression, which is probably why her endometriosis turned into ectopic decidualization. Unfortunately, the differentiation is hard to make antenatally, and the diagnosis is often made intraoperatively, as with our case. So moving on to the case study, our patient was a 39-year-old woman with a long-standing history of painful and heavy periods. She was diagnosed with endometriosis. She was on prior treatment using Provera for symptom control. She had 2 pregnancies, both planned for elective caesarean deliveries due to previous obstetric considerations. Importantly, she also had gestational diabetes. However, it was controlled completely by her diet, so it didn't really affect the pregnancy. So during her first pregnancy, the main concern was that she had placenta previa, which was identified during routine antenatal screening. She presented twice to triage for clinical assessments with abdominal pain, but both the scans were normal. At 37 weeks and 4 days, she was delivered by elective C-section with blood loss of about 650 ml. There was no postoperative concerns. In her second pregnancy, which is this one, again, it began similarly. She didn't have placenta previa this time. She did have diet-controlled gestational diabetes, and all her antenatal appointments were normal. However, the situation changed during the C-section. During the operation, the surgical team noted ongoing bleeding that did not respond as it would have normally to the measures we were providing. So no, it didn't respond to the oxytocin, it didn't respond to the TXA. It was hard to see the surgical field during the ongoing bleed. But what my consultant who did the surgery noticed that the outside of her uterus So the posterior wall was really vascularized and edematous. The areas were really flimsy, and they had loads of adhesions. There were tears into the serosa and the deeper myometrium on the external uterus. There were also dense adhesions that pulled at the structures surrounding the uterus, raising concerns about where the bleeding was coming from. Despite clearing the cavity, the bleeding continued. These features were obviously not typical of a normal, uncomplicated pregnancy, and it was also very different from her previous placenta previa pregnancy. In total, she lost about 900 ml of blood and was transfused postpartum once we got the bleeding to stop. If you can see the images here. So this was once we managed to get the bleeding to stop. The stitches initially were not holding the wall properly because they were just so flimsy, but eventually it was okay. You can see how tender and fragile all the tissue looked. So we took 2 samples from the outside areas. It was a 3 centimeter blood clot and a brown fragment measuring about 3 centimeters as well. They were both sent to pathology. And then basically what the pathology came back was that it was vascularized decidualized stroma. There was occasional glandular structures which showed similar lining to the endometrium. There were features that could have been consistent with placental tissue as well. So all in all, there were progesterone-induced changes. In other words, what we found was the patient's endometriotic implants were also on the external posterior uterus. Sorry. And that they'd gone through decidual transformation. So why is this important and what are the clinical implications? Well, firstly, the ectopic decidualization led to significant intraoperative hemorrhage, which can happen to other women with similar stories of endometriosis, especially if they have the PRB receptors. Secondly, the condition can mimic malignancy both macroscopically and microscopically if we're not aware that things like this can happen. If the endometriosis is also expansive and it's attached to their bowels, it could cause bowel perforation or pseudoappendicitis-like features or an acute abdomen kind of features. There's one case that's reported, and we've referenced it. In case anyone wants the references, I can always send them over. So that's that. Also, with more women delaying pregnancy, the prevalence of endometriosis is rising, which means the chance of encountering cases like this is really high as well. So we just want to promote the recognition of like how to prevent misdiagnosis of such cases, I guess. Luckily, the decidualized tissue typically does regress itself within 4 to 6 weeks, so most women don't have an issue postpartum. As the progesterone levels fall, the decidualization tissue falls as well. And yeah, that's pretty much it. If anyone has any questions.